Now I'd like to call upon Dr. IlinKinimi, our pediatric pulmonologist. She'll be talking for the next 10 minutes about how to take care of breathing problems in SMA children, and over to you, ma'am.
Thank you so much. I'll be speaking about respiratory management in SMA children. So why is this topic very, very important and very crucial to understand? Breathing in children with SMA. So we are all aware already and being told repeatedly that respiratory problems are the leading cause of illnesses in SMA, or the leading causes of our kids coming to the hospitals. Most common cause of death for children, especially with the SMA type 1 and type 2. And we are really reiterating that respiratory care interventions are essential for our children's survival. Despite of medications, we still need very good respiratory care, and of course the quality of life and comfort of our children with SMA. The problem with our children with SMA is there is a muscle weakness. We all know muscles are involved for everything, every activity that involves a muscle, especially our respiratory system. Children are unable to cough, so they are unable to bring out their secretions, and they land up with recurrent pneumonias, recurrent lung collapses. The lung is not a normal lung, so it doesn't move like yours and mine. It doesn't have the capacity to move like your lung and my lung, a normal lung, right? And even the airway resistance is very high because these children are unable to cope up with even their normal breathing, and especially during respiratory tract infections, especially when you have a child with even a very mild viral infection. So to you and I, we may just have a normal cough and cold, but these children can land up with life-threatening emergencies in our ICU, land up with ventilation, and many much more problems than our regular kids. Eventually, most of these children will land up with respiratory insufficiency, and these problems are first detected during sleep. And these children, some of them eventually also go on to require daytime respiratory support. So the muscle weakness, just to make it very simple, when we breathe in our inspiration, this is extremely important. These muscles are involved. Expiration, all the coughing, the blowing out, and all these muscles that are involved in expiration are also very weak. The bulbar muscles, extremely important. That is important for swallowing, for eating food, for able to cope up with different types of food, liquids, solids, semi-solids, in speaking, and all these things that are so essential for your nutrition. The swallowing and the nutrition also becomes affected, and that is the reason why some of our kids come in with silent aspiration. We don't know that they're actually even their saliva is going into their airway, or in food particles are going into their airway, and because this muscle coordination may not be adequate in these children. So very important to understand the basic support of our existence, literally the swallowing mechanism, our breathing mechanisms, because the muscles are not at normal, not working normally. So these children face a lot of problems. So as I've said, cough is not adequate. They are not able to clear secretions. Sleep-related issues where the carbon dioxide starts building up because the gas exchange gets affected. The chest wall is also affected in its growth, and also the lung, and recurrent infections that again worsen the muscle weakness. And if a child comes into ICUs, get intubated, ventilated, it's very difficult to extubate them as well. And the spine starts getting into a scoliosis, and this further worsens the lung volume, and these children develop restrictive lung. So it's a vicious cycle of aspirations, swallowing as well, and all these children also eventually have reflux, which worsens the respiratory system. So this very important key diagram. And to put it very simply, when we are having a normal breathing, there is no problem. But when these children have muscle weakness. We need to evaluate swallow, not just by a test like a barium swallow, but a speech therapist needs to evaluate swallowing of liquids, solids, swallowing of different consistencies of food. There are still children who choke only on liquids, or children who are not able to take solids, or their eating time is so slow. Some parents come and tell me their feeding time is 1 hour, 1.5 hours. There are some children who come in with caries because their food is in the mouth for so long, they're unable to chew and they're unable to swallow, right? Is the child having recurrent cough or cough every week, every month, or is the child coughing with feeding? And sleep, again, a very tough way to analyze how the child is sleeping, but we do have parents who say child is very restless, not sleeping well, gets up very groggy and tired, and basically, sorry. So these are what we ask in your history when you come to us. And once the problem begins, the cough is not adequate, your swallowing is a problem, and you are landing up with recurrent aspirations, pneumonias, recurrently coming to the hospital, we know that we have to think about other measures. Do we need to teach you airway clearance technique, chest physiotherapy, cough assist? These are the techniques that we need to teach you. We also need to now start looking at sleep studies, right? So we do a pediatric sleep study. Should we be doing tube feeding? Should we be doing PEG and gastrostomy and fundoplication? Because once the ball starts rolling, it's very, very difficult for any of us, despite of our best management, because we know it's a progressive muscle weakness. And once this ball begins rolling, it's very difficult, and very few things are in our control. So what can we do? As we say, I repeatedly say to parents, and some of you already here know that it's like a soldier going for war. You don't know when the war is, right? But each day you get up, you need to exercise, you need to maintain your nutrition, your exercising, your routine. You can't just get up and go to a war one day. You can't just start firing guns. You need to how to fire the gun. You need to be ready. You need to be disciplined. You need to be able to climb a mountain. You need to be able to swim. So we as physicians and also as parents and caregivers need to understand we have to be prepared. There is no like we will wait and we will watch, and so many times we see parents, because the problem is not there staring at them, they wait. So, and this is the reason why we are conducting so many of these programs, calling each one of you. Sometimes we ask parents to speak to other parents, because sometimes when I tell the parent this is the thing that we anticipate, the parents are like, you know, it doesn't sink in, because that's the way it is. But we need to identify, anticipate risk. You know that this is a progressive muscle weakness. The child should be able to cope up with all the respiratory infections, no matter how minor. If the child is coughing, there's a voice change, unable to swallow, choking, these are our red flags. And we need to repeatedly keep asking, is the child aspirating? Is the child able to swallow? What is the state of the spine? Have we checked for the sleep studies and any other comorbidities like children with reflux or any other such issues? So there are various interventions that we can do, like I said, but I still think sleep study is extremely, extremely important. It is expensive test, but if we get that done, at least a lot of things are picked up. Swallowing assessment by a speech therapist, lung function tests in older children, airway clearance techniques by a physiotherapist. Therapists have to be taught, including some of our kids already on cough assist machines, NIV, the BiPAP systems, whether it's an acute child or a child with chronic respiratory failure, nebulizations, mucoactive agents, routine vaccination, and of course the most important again is nutrition. Yeah. So this is a child with SMA, 11 months old, SMA type 1, diagnosed at 8 months, so many aspirations, ICU admission, and you can see on the x-ray this right upper lobe collapse, and the parents say maybe have gone into the hospital 3 or 4 times, each time landed up in the ICU, very sick, very severe. So what our team has done is we have initiated the BiPAP, and that when the child came in very sick, oxygen saturations of 85, the child was so tachypnic, but we managed to start a BiPAP, and of course we averted invasive ventilation. That itself is a big, big task, and we eventually sent this child home on BiPAP. So after 2 months, we got on to do a sleep study, and a child was seemingly well, not having any problems with sleep. So when we do a sleep study, we look at various parameters: obstructive apnea, mixed apnea, hypopneas, and what we found was this child was actually having 117 hypopneas, which was so severe, and that is the reason why also the child was unable to cope up with respiratory infections, and each infection was gradually getting the child to become weaker and weaker. So the child had a lot of problems with the mask and the BiPAP machine. It took us 3 months, but eventually the child was able to get onto adequate BiPAP settings, titration. We do. Another kid, 4-year-old with SMA, was 10 kgs, which is obviously extremely underweight, recurrent hospital admissions, had difficulty swallowing. This child was taking almost 1.5 hours to take about 5 spoons of food, always choking on feeds, but the parents were still thinking that that was okay. They were not aware that it's not safe to continue feeding the child. What looks like a very bad X-ray bilaterally, there's so much diffuse infiltrates, and probably this is a sign that this child was already chronically aspirating, and this part of the lung was already collapsed. So again, we did a sleep study. It showed about 59 obstructive apneas, 104 hypopneas, and there is no way, like you and I can pick this up. It's only through the sleep study. And so again, very important to reiterate that these children will benefit. So BiPAP initiation took about 5 to 6 days because the child was not able to use the mask. Swallowing assessments were done. The child, we had put on NG tube feeds because the parents were not willing to do a PEG and a gastrostomy right away. And there was a dramatic improvement with weight gain and no further hospital admission. So it also takes parents and us to reach this level to understand the importance of the respiratory system and how important that we need to intervene early. When do we use BiPAP? Sorry, there's a spelling error. And NIV, what we call non-invasive ventilation. When we anticipate sleep-related problems and we are getting their sleep studies done early, hypoventilation when we're checking the carbon dioxide levels, especially early morning, late night. In the event the child comes crashing in with respiratory illness, like the case that I showed you, there are a lot of these kids with chronic respiratory failure, and they don't get picked up until they land up with respiratory tract infections. It forms a part of palliative care when you know that we can't do much more except help this child at least to be able to breathe well. And of course, as a preventive measure, children with scoliosis, no child should be going on to any scoliosis surgery without the BiPAP established. And because post-scoliosis surgery, it becomes very challenging. These kids collapse their lung, they're not able to be extubated, and it's a whole lot of challenges, so we don't advise surgery prior to initiation. So why this BiPAP? Why are we harping about this? We are looking at child survival rates, prolonging it, and especially when we have drugs and medications available now, to relieve their difficulty breathing, all the carbon dioxide deoxygenation, oxygen desaturation, or carbon dioxide going up. It helps that. All the sleep-related breathing issues are circumvented by using BiPAP. Some children also have pulmonary hypertension because of these chronic lung issues. They are able to function better in the daytime. They're fresher, brighter, more alert, able to concentrate. Of course, growth and development is absolutely dependent on that. And most children, when we establish BiPAP well, they also gain weight. And of course, we are preparing our kids for any respiratory failure and recurrent pneumonias, and of course, their problems when their children have very high carbon dioxide levels and go into chronic respiratory failure. There are so many different interfaces now. Like I think in the last 5 years, we have established and we are able to source and get so many different type of fantastic interfaces. There is no dearth of interfaces now, even in our country, and we shouldn't be saying that, oh, now this is not available. We are able to source every kind of these the interfaces for these kids. This child on a tracheostomy with a BiPAP. and various types of interfaces which we didn't have earlier. So every kind of interface is available in the country now. So putting it all together, we need to understand what is your child's baseline. Is there anything different? Is the child having recurrent cough, colds, difficulty swallowing? Understanding what it means to know that the child's not breathing well. What do we need to do? Do we need to do BiPAP? Acute illness management, parents have to be alerted, and whether they have care providers that understand their disease and understand where to go. Airway clearance, physiotherapy, and all the secretion management techniques. Respiratory support, like I just mentioned, BiPAP, nutrition, hydration, and we have a very low threshold to start antibiotics on these kids. Routine immunizations, especially the influenza and the pneumococcal vaccine. Supplemental oxygen, time again we face this crisis that those children who come in very sick and severe, especially with neuromuscular diseases, when we give oxygen to these kids, right, without the BiPAP, we're going to cut off their central respiratory drive, and we have seen so many times, I think in the last 6 months, the child brought in with oxygen 80, and then you give oxygen, the drive worsens, the child literally goes into, CO2 narcosis, comatose. We have carbon dioxide hitting 120, 130, and so we get distress calls for that. That the key to this is start the BiPAP first, and the oxygen is an additional thing that you need to put on. But if you give oxygen, we just cut off the drive that was there, and we need to first do the support, ventilatory support, like a BiPAP first, and then the oxygen. So again, this is something that we are trying to tell clinicians about. So all these children, we need to anticipate problems. We as clinicians repeatedly clinically assess them. Appropriate tests, not random tests that are of no use. Technology usage right now, we have video consulting lines, we have ways to help kids with, even for our cough assist machine, BiPAP machine, MDT management, and of course repeatedly telling us about chest physio. These have increased our life expectancy of these kids. Hospital admissions have decreased, and of course the patient and the family is also benefited because at least some quality of life changes. So in our program that we run between Baptist and our hospital, so we have about 372 SMA kids, and that I think we are, I might be quoting less numbers, and our team has done 112 sleep studies, and 68 children have been started on BiPAP out of these SMA, and 17 we had to do it under acute settings. The child came in crashing in. 9 are on tracheostomy with BiPAP. 22 have had gastrostomy and fundoplication, and we have 10 children who are on cough assist every day now. So thank you all so much.
Thank you so much for the wonderful talk. Now, I request Dr. Meenakshi ma'am also to please come up on the stage, and I request Dr. Madhuri, the head of Department of Pediatrics, Bangalore Baptist Hospital, to present a memento to both the speakers, Dr. Meenakshi ma'am and Dr. Alvin ma'am.
least to be able to breathe well. And of course, as a preventive measure, children with scoliosis, no child should be going on to any scoliosis surgery without the BiPAP established. And because post-scoliosis surgery, it becomes very, very challenging. These kids collapse their lung, they're not able to be extubated, and it's a whole lot of challenges, so we don't advise surgery prior to initiation. So why this BiPAP? Why are we harping about this? We are looking at child survival rates, prolonging it, and especially when we have drugs and medications available now, to relieve their difficulty breathing, all the carbon dioxide deoxygenation, oxygen desaturation, or carbon dioxide